I'm just gonna roll. Hey, my name is Matthew Delaney. We are going to talk today for the next couple of minutes about hidden medical legal pitfalls. Up front, I have no financial disclosures related to this at all. I work in the emergency department at the University of Alabama at Birmingham. I'm an associate professor. I'm an assistant program director for the residency. And I do some medical legal defense work. And I think for this talk, one of the things that I do need to disclose is that I'm a practicing physician and I've been a defendant in really 2 to 2.5 cases. So I get the stress that's associated with being named in a lawsuit. I get the fear of seeing a patient and if there's a bad outcome, wondering, is this going to turn into a lawsuit? And just the final disclosure is all of the cases we're going to talk about today are public record. You can go on Google. I can send you a link if you want. So I have no proprietary or hidden information here. But when we talk about risk, medical legal risk comes in several forms. Sometimes the risk is really obvious and comes straight at us. And so this is a case where the second you see this case, you know that this is a high stakes encounter. And I think of this as a patient who shows up in the waiting room of the emergency department. They have chest pain. It's a really busy day. It takes about 4 to 5 hours for them to finally get back to the back. And it turns out they have a STEMI. And they have to go to the cath lab. It's a delayed STEMI activation because they sat in the waiting room for so long. And they end up having heart failure and having really bad long-term outcomes. So I see that case. In that case, I know that that's a risky case. That's a bad outcome for the patient. There's a high likelihood that that patient or their family is going to want to talk to a lawyer about that case. And this is just risk coming straight at us. Nothing we can really do about it. Sometimes the risk is really hidden and you don't even see it coming. And this is the healthy 30-year-old that comes and checks in, comes to the urgent care, has really cough, cold, congestion. It's the middle of flu season. They look fine. They go home and they actually die of meningococcemia the next day. So this is a well-appearing patient, had an absolutely horrible outcome. But if I saw that patient 1,000 times, I don't know that I would have picked that up in any of those encounters. And so risk can come at our face, but then some of these cases, really these needles in the haystack are just kind of hiding there. Not a lot we can do to mitigate that risk. And what this has kind of left me feeling like a lot of times when I'm working in the emergency department is I feel like I'm just waiting for one of these cases to come in. Is it my day for the unlucky lottery ticket, my numbers to come up? And that's a really kind of fearful way to practice. I didn't get a lot of joy out of practicing that way and viewing each encounter as this is the day that something bad's going to happen to my patient and subsequently happen to me. So I started to look around, and I think outside of the times where the risk is very obvious or the risk is totally invisible, there are several things we do on a daily basis that I think actually carry a fair amount of medical legal risk. And so what we're going to talk about is these 4 areas of risk where we do this on a near daily basis. There is a fair amount of inherent risk, but there's some strategies we can use. We can look to the literature, we can look to previous cases and say, how can we dial the risk down in these encounters? And so we're going to talk about metadata. We're going to talk about prescribing fluoroquinolones. We'll talk about discharge paperwork, or really the entire discharge process, whether that's out of the emergency department, whether that's out of an office or an urgent care. And then we're going to talk about recording providers, which I think is the one that really gets most of our blood pressure up the most. But jumping in metadata, this is also, what I'll say as a disclaimer to this is that I don't make any of these rules. I don't like most of these rules, but these seem to actually be the rules. And so you can direct your hate mail towards me, but a lot of this is put on us. But metadata is a great example of risk that we didn't go looking for that's certainly there. So at its most basic, and I'm not a computer guy at all, metadata is data about data or information about information. And it's kind of inherent in the way that computers compute, that when they do their computing functions, they create this kind of hidden amount of data, this data about data or metadata. And it comes in 2 forms. There's system metadata. So think of this as a timestamp. So when I logged on my computer at work this morning, it said Delaney logged in at 8:45 this morning. When I log off, it creates a separate line of system metadata. So this is always running in the background and kind of tracks what we do. But there's also application metadata, and this is, I think, where it can become really problematic for us. Think of this when you're using a word processing, track changes feature. So every keystroke, when I put my password in incorrectly this morning and I deleted it, that created application level metadata that's part of the computer now. It can actually be discovered. And metadata, it's not a new thing. So since computers were designed, metadata was around. And we didn't hear about it for a long time for a couple of reasons. The first was that storage used to be prohibitively expensive. When computers would fill up entire rooms, metadata would be created, it'd be stored really briefly, and then would be discarded just because from a practical standpoint, they couldn't keep the data around. It's too expensive to store it. The other reason we haven't heard about metadata until recently is because the process of searching metadata used to be really, really difficult. And you actually needed almost a computer engineer to go in and get some of the metadata. And it was just too expensive, too time consuming, even if the data had been saved for somebody to go in the process of a lawsuit and mine the metadata. The problem is now in the smartphone era, it's very easy to mine metadata. In fact, if you look in any of the kind of lawyers' trade journals, they'll have a conference, oh, come to Kissimmee, Florida, and we'll teach your paralegal in a weekend how to mine metadata. So the information, this metadata that's always been there is now being saved really indefinitely, certainly longer than the statute of limitations around lawsuits. So for several years at least. And then it's actually really easy to search metadata now. And of the 5 cases I've looked at or defended in the past 2 years, every single time they've looked at metadata. So this idea that this information is there and is searchable is the reality when we look at how cases are litigated in 2020. We started to see metadata pop up in the medical legal world really a couple years ago when Vioxx came on the market. And if you remember, Vioxx was supposed to be the wonder drug. It was the anti-inflammatory that didn't cause any of the bad things to happen to patients that we associate with anti-inflammatories, except for that turned out to not be the case. And as soon as Vioxx hit the market, we started to see an increase in the rate of adverse cardiovascular events. And the makers, Merck, said, no, listen, this isn't related to the drug. We knew nothing about this. And what happened was some lawyers got involved and an investigative journalist got involved, and they pulled up some old emails back when Vioxx was in phase 1, phase 2 studies. And in an email draft, somebody had written something to the effect of, hey, we're starting to see a spike in cardiovascular events. And then they subsequently deleted that, then sent the email, but that created metadata. And it was actually that discovery of metadata relating to Vioxx and these cardiovascular adverse events that really helped get Vioxx off the market. And when this happened, every single plaintiff's lawyer in the country sat up and said, we really need to think about getting easier access to this metadata. There are a couple of really crazy sounding cases. There was a case a couple of years ago, a patient came in for really quasi-elective spinal surgery. They had degenerative disc disease, they were getting a laminectomy. And they went into the operation. The operation was fairly uneventful, at least per the surgeon, and they woke up and they were paralyzed from the waist down. Obviously a really bad, unanticipated outcome. There's a little debate about what actually happened from the surgical standpoint. And it went to trial, and they named the surgeon, and then they named the anesthesiologist just as party to the case. They pulled the metadata from the electronic health record and realized that the anesthesiologist had charted the entire case before the case started. So they'd done start, stop, they'd falsified some vital signs. And what ended up happening was that the surgeon was dropped from the case and the anesthesiologist lost several $1 million. So again, when cases like this happen, horrible case, horrible outcome, but that metadata was damning in that situation. And again, this really just pushed the lawyers more and more down this rabbit hole of we got to really look for the metadata. The lawyers did an interesting study, quasi-study that they haven't really published in any peer-reviewed journal a couple of years ago, but they went into inpatient hospital records. And what they said was, let's look at every time in the medical record that a chest x-ray was documented as within normal limits, or WNL. And so they went and pulled all those cases. And then they said, all right, let's actually go to the metadata and look at when they documented within normal limits, how often did they actually create system metadata and access an image of the x-ray? And they found that only about 30% of the time when the clinician would document x-rays within normal limits, that they actually could prove that they had accessed the image. And so the lawyers actually joke, one of them said to me a couple of weeks ago, when you guys say WNL, we think that stands for we never look. So when it comes to metadata, it's out there. And when you think about if you're going to go to trial for something, the worst thing you could show up and be proven to be is a liar. And so I think all of us approach patient encounters with the goal of not lying. But something as simple as clicking within normal limits but not accessing the image, when that's brought to the light of day, suddenly I'm a liar. I've actually falsified the medical record. And that's when people start pulling out checkbooks and cases settle not in our favor. So metadata, I think, is out there and is being increasingly scrutinized. A lot of folks that typically try to advocate for us have tried to keep this out of courts. The American Medical Association has spent a lot of time, money, and energy really fighting the state to state, should metadata be allowed in. But the problem is that there's a lot of money. The med mal industry is a juggernaut. And as much money as clinicians are putting in to try to keep this out, the lawyers, they make the rules. They run the country. So the idea that metadata is going to be a part of almost every lawsuit is the reality now. And so I think, again, the risk is there, and I think awareness of metadata and really just being careful. Every time I chart something, every time I use a computer, I need to know that I'm leaving a digital trail of breadcrumbs. In terms of dialing the risk down, we should be honest. I think the next step would be, if you ever look at the chart and there's a really egregious error. So I work with learners, and we saw a child, and the learner came out and started the note and said, the child is lethargic, which if you take care of children who are potentially sick, is a really hot, scary red flag word to use. I went in and saw the kid was sleepy. It was the middle of the night. And the kid woke up and was fine and fussed at me. And so I came out, the chart said that the patient was lethargic. And so I made the correction, but I actually did put in parentheses. Initially, this was charted that the patient was lethargic. That was before I was able to see the patient. I don't typically, in most cases, if I'm making minor kind of grammatical corrections, go to the level of explaining, hey, listen, I changed the chart. But with metadata, again, the fact that lethargic was written and deleted would potentially be discoverable. So if you have scribes, or if you have learners, or other people that are making your chart or accessing your computer system, just be aware. And I think if a case jumps out where you're like, gosh, I wish that had not been written down, well, it was written down, it's now saved. So I think those would be the instances where a notation of, hey, listen, I'm the clinician in charge, this is what we're gonna do, would I think mitigate that risk a little bit. Again, I wish metadata weren't out there, but the reality is it very clearly is a hot medical legal topic in the current climate. Fluoroquinolones, this is an interesting area of risk. These are really great antibiotics. I get no money from the fluoroquinolone industry, but if you look, these are blockbuster meds, over 300,000 prescriptions a year in the US. And the reason we use these medications so often is because they're very effective antibiotics. They cover a whole lot of pathogens, a lot of the common players. They get a lot of the more resistant pathogens we worry about. And they are still in a lot of the guidelines. If you look at some of the recent guidelines of community-acquired pneumonia, for patients with comorbidities, a recommended first or second line agent for outpatient therapy is respiratory fluoroquinolones. It's really actually one of our only good options for monotherapy. So at the basic science level, fluoroquinolones are effective antibiotics. From a practical standpoint, these we're told by our peers, hey, these are the recommended agents to use. But the problem is that all drugs have a risk-benefit profile, but when we look at fluoroquinolones, the potential downsides, and the longer these have been on the market, the number of potential downsides really are starting to stack up to the point that I think we have to be very careful about how we use these drugs and really explicit about that risk-benefit profile when we use the drugs. The way we find out a lot about these side effects is really, again, the longer they've been on the market, the more reports have come to the FDA. People say, hey, listen, I took this medication, I had this symptom. And again, it may be me just saying something crazy that I thought the world was purple after I took fluoroquinolones, but the more associations we get between somebody saying, hey, listen, I'm having this symptom and I received this antibiotic, then we start to get patterns that develop. And one of the first patterns that developed was this risk or this association between taking a fluoroquinolone and then developing a tendinopathy, so tendinitis, but tendon rupture is the big one. I care if a patient gets Achilles tendinitis. I really care if a patient ruptures their Achilles tendon because the trajectory of those two things is going to be really different. The good news is if you look at healthy patients, take a patient who's not on a fluoroquinolone, put a patient on a short course of fluoroquinolones, the incidence of tendinopathies, and tendon rupture being the big one, is going to be 4 times higher in the patient who got the fluoroquinolone. And so that's good news because a healthy patient has a very low day-to-day risk of rupturing a tendon or getting tendinitis acutely. And if you take a very low number and multiply by 4, you still have a very low number. So I think in a healthy patient, if you need to put them on a fluoroquinolone, the risk really does seem to be, from a tendinopathy standpoint, pretty low. The problem is when you think about who's the last patient I gave a fluoroquinolone to, it's not typically a young, healthy patient. So other risk factors or other kind of demographic features start to really increase the chance that a patient will develop an issue with their tendons. So men are significantly more at risk. Patients over the age of 60 and patients with chronic renal disease. When I see that list, that actually starts to sound like a lot of my patients where I start to reach for a fluoroquinolone. So we're going from a 4-fold risk and things are starting to climb. This is the category that really worries me is any patient who's taking a corticosteroid. And prednisone is the one that's been reported most often, with a fluoroquinolone has a 46-time increase in the chance that they have a tendinopathy or a tendon rupture. The problem is, for years, my approach to patients who came in with COPD was, you got a COPD exacerbation, here's a respiratory fluoroquinolone, and here's a short course of steroids. And again, that's a common prescribing pattern for lots of us. But when I look at that patient, 46 times the baseline risk of tendinopathy, plus add in if they're male, plus add in if they're over 60, throw in some chronic kidney disease, and suddenly that low number actually becomes a really kind of something I would reasonably worry about in this patient population. These medications, again, blockbuster meds, so millions of people are getting these medications, and we started to see other complications come up. There's a risk of neuropathy that's out there that's associated with fluoroquinolones. The mechanism is really poorly understood and hotly debated, but the association seems to be clear to the point that this is now showing up in courts. And if you, next day you're off, watch daytime television, you'll see these ads that say, if you or your loved one has been harmed by insert the fluoroquinolone of the week, call our law firm. You know, we're going to vindicate this. But neuropathy and chronic pain exacerbations are now associated with fluoroquinolones. A couple of years ago, folks started to worry about, is there an issue between taking a fluoroquinolone and developing aortic pathology, so aneurysm and dissection, with aneurysm being the one that was most commonly reported. Again, the mechanism here is a little bit strange. It probably has to do something at the cellular level. Fluoroquinolones are thought to muck with how we make and regulate collagen, there started to be these rumblings a couple years ago, 2017 and 2018, that said, hey, maybe fluoroquinolones are a problematic drug when it comes to the aorta. Pasternak et al. Had a study out in 2018 in the New England Journal of Medicine, and they looked at two groups of patients. They looked at patients who took fluoroquinolones, and then they looked at a similar group of patients who took amoxicillin, same duration. And they found that at 60 days, the incidence of acute aortic pathology, so most commonly aneurysm, but also aortic dissection, was twice as high in the group of patients who took fluoroquinolones compared to amoxicillin. So big study, well done study that clearly shows a statistically significant increase in the incidence of acute aortic pathology after a short course of fluoroquinolones. Risk to us here, this is, again, when you start seeing ads on television asking if this drug has harmed you or your loved ones, clearly there's a big medical legal risk here. There's a lot of money at play. And really, if you look at how fluoroquinolones were rolled out, it's the perfect storm. So they were blockbuster medications. When I was in med school, I think every single day somebody would show up with box lunches and offer it if you would take a pen that said, any of these respiratory fluoroquinolones on them. So very popular medications have made billions of dollars for the drug companies. And the other thing that's happened is this has all come at a time where the general public has really started to use the internet. And one of the things that we've seen is there's this really, really robust, vibrant community of folks, they call themselves Floxies on the internet. And we did an article about this risk with fluoroquinolones a couple years ago. And we published it online and actually had to shut down the comments section because the Floxies took over the comments for the article. And so you've got very popular medications. You've got a lot of people who are now connecting across the world, across the country, saying, hey, listen, I took this medication and things got off track. And so it really started this grassroots movement in terms of, hey, these are risky drugs. People are being harmed by these medications. A lot of stuff in medicine is a self-inflicted wound, so I don't know who this physician is, but this is a book I saw at the airport. So obviously, the drug companies pushed the drug out there, the Floxies caught wind of this, and now people within the House of Medicine are profiting or trying to profit off of this potential risk here. The FDA has not necessarily helped us from a risk management standpoint. So when we look at the warnings and the black boxes they've put around the use of fluoroquinolones, 2008, they said, hey, listen, there's this issue with tendinitis and tendon rupture. 2013 was the first mention of, hey, peripheral neuropathy seems to be an issue here. 2016 was, I think, the least helpful. They said that there's a risk of pain and, quote, adverse reactions, end quote. They don't clarify that any further other than people were having, quote, adverse reactions. So we should watch out for that in all of our patients. And they sent us all letters, communications to providers. They warned us about this. That's an incredibly vague warning. And then even more recently, they mentioned that there's an association with hypoglycemia and then mental health issues with fluoroquinolones. So the FDA has created this enormous black box around this very broad range of symptoms and said, hey, we've warned you on the clinical side that fluoroquinolones are associated with these potential adverse events. Then they weighed in on this risk of aortic pathology. And they said if you have a history of peripheral vascular disease, hypertension, Marfan, any kind of connective tissue disease, or elderly patients. And so for me, I look at this and I'm like, if you have Marfan syndrome, I probably will look at something else. I don't want to stress your already stressed aorta, but an elderly patient is exactly the patient I typically would reach for these medications. The risks really, when I first started reading through this, seem overblown. But then I started to look at what are the lawsuits, what do the lawsuits look like that are coming out of this stuff? Because it seems like it'd just be a nuisance lawsuit. Unfortunately, that's not the case. So one of the first big lawsuits, 2010, is an 82-year-old male, was functional, lived independently, took a short course of fluoroquinolones and had bilateral Achilles tendon rupture and had to go into assisted living. So filed a lawsuit and won $1.8 million. So not a nuisance sum and not a nuisance outcome for the patient. And this case kind of pinged around the internet and the plaintiff's lawyers were all over this. And so we started to see really a surge of cases related to fluoroquinolone use and potential adverse events. The last numbers I could really find were 2016, and at that point there were 5,000 lawsuits pending in US courts involving an allegation that a fluoroquinolone was related to an adverse event for a patient. Obviously, these drugs are still popular. This number is not lower now, but this is a very, very real medical legal threat. I only take defense cases. I don't take plaintiffs' cases. But I got a call a couple of months ago actually, from a lawyer in Philadelphia, and he said, I'm a plaintiff's lawyer. I want an ER expert to testify against fluoroquinolones to take the plaintiff's case. I said, I don't take plaintiff's cases, but thank you. And he said, well, you just look at the case. I said, oh, I'll just read it. I don't want to work for you. I'm interested in fluoroquinolones. I'll read this. He had a patient or a client who was a 55-year-old trucker who had long-standing diabetes, had long-standing lower extremity neuropathy, thought to be associated with his diabetes, who had come to the emergency department, was diagnosed with a community-acquired pneumonia, was given 1 dose of levofloxacin by the ER doc, and was admitted, and got changed over to azithromycin, did fine in the hospital, was discharged 24, 48 hours later, went home, went back to work, and a year later, failed their Department of Transportation physical because their neuropathy was worse, and they thought they weren't safe to drive trucks. And they sued the ER physician based on a one-time dose of levofloxacin, with the allegation being that that one-time dose was the thing that tipped over the neuropathy, made the neuropathy to the point that this patient couldn't work. And I read the case and I called the guy and I said, I kind of laughed and I was like, listen, this is not going to be a good case to try. There's no chance a jury is going to listen to this. And he said, I don't need you because I've already got 2 other guys who are willing to testify that that is the issue, that it was that dose of quinolone that caused this guy to not be able to work. So do I like that? Absolutely not. Do I think that that's reasonable? Absolutely not. But unfortunately, that's the reality we're living in. These medications, the FDA has identified that they're risky. The general population has identified they're risky. The lawyers have identified that they're potentially risky. So I think we're stuck with these medications. I think they are very effective medications in the right patients. I think they're safe in the right patients. But I do think we have to acknowledge that risk is real and look for ways to really kind of mitigate that risk. I hate electronic health records. Beyond the metadata, it's just a source of constant headache for me. But some of the things that they're good for is, I think, for risk management kind of discussions with patients. What I can do is create a macro, or depending on who you use for your EHR, a dot phrase, but some kind of pre-populated text. And I think that the thing that's really important is that when I see a patient and I think, hey, I think a fluoroquinolone would be a good agent to use for you, ethically the right thing to do is to talk to our patients. And what I typically go in and say is, look, you've got an infection. There's a medication on the market. It's in this category of fluoroquinolones. Most people have kind of heard of some of the trade names. And I say, look, it has some risk, but I think in your situation, the potential upsides outweigh the potential downsides. And I tell them, I would give this to my family member and I wouldn't think twice about it. And then I say, listen, the big issues we worry about are things with your tendons. You can get some kind of burning pain or numbness. And we're going to start you on this medicine if you're okay with it. But if you have any issues, come back and see us. Let us know, or go straight back to your primary care physician. And again, this does feel like defensive charting. But the reality that's been forced upon us is that I do think we have to acknowledge the elephant in the room, the elephant being that fluoroquinolones are getting blamed for a lot of stuff, and there are a lot of lawsuits involving these medications. So what I do is I talk to the patient, and that takes 20, 30 seconds. I think it's the right thing to do to tell patients, hey, this medication is less perfect than some other medications. But then we want to give ourselves credit, and we want to say, hey, listen, we talked to them. This was a kind of a game time decision. They were okay with it. I was okay with it. Now, that discussion and that documentation doesn't mean that we couldn't be sued. We can be sued for anything. But what that does do is give us a very defensible chart. And I think if we use these medications and there's an adverse event, having had this discussion and document that discussion is really going to decrease the chance that a plaintiff's lawyer is going to want to pick up that case and run with it. So some variation of, hey, we tried to not have a bad outcome. We avoided it in especially high-risk patients. But yeah, we acknowledge it and we're going to move forward. Discharge process or discharge paperwork is another source of actually pretty big medical legal risk that I hadn't thought about for a long time. I work in a busy urban emergency department, and really, in my hands, the discharge process was always an afterthought. I'd be running into one room and they'd say, room 7 is ready to go. I'd be like, oh, that's great. Just give them some chest pain paperwork. And I had already talked to the patient, but the actual, how do we discharge the patient? Really, just take care of it. I'd have a medical student do it. The nurse would do it. If I was working with a nurse that was going to bend the rules, I'd say, just discharge them with verbal directions. We'd save a tree and not have to print out the 30 pages that come out of our system. And it turns out that's not a great approach. There's an interesting study, Engel et al. Published this in 2009, and they looked at how well do patients understand their discharge instructions. And this was an emergency department patient population, but it easily could be extrapolated to primary care office, urgent care, surgical center, same-day surgery. Anytime you're seeing a patient and telling them, here's some things we want you to watch for, here's some things we want you to do. And the interesting thing about this was a very educated patient population. So in this patient population, 60% of the patients had at least a bachelor's degree, if not higher. For a lot of us, I work in, those are not the numbers we see in my shop. My patients have much lower rates of education and much lower rates of healthcare literacy. And so I think looking at this study, they took a patient population that is, I would think, more likely to understand and really kind of get their discharge instructions. It turns out that a fifth of the patients did not understand their discharge instructions. They asked some simple questions. Who did they tell you to follow up with? What did they diagnose you with? And they were whiffing at very basic questions, which I get it. I'm a bad patient. I probably would fail the test too. The scary part was that out of that 22% of patients who didn't understand, they failed the quiz on their discharge instructions, only 30% understood that they didn't understand. And that's me. I'd be like, oh, I don't understand, but I'm sure I've got it figured out. So you got a fair amount of patients leaving this emergency department with high baseline levels of education and literacy and healthcare literacy who didn't understand their discharge instructions and were oblivious to it. So the chance that they're gonna make good decisions on the basis of what we told them is actually pretty low. So there's a lot of confusion on our end clinically about what should we do, and then patients are kind of stuck trying to put the pieces together and say, well, what did they actually want me to do? This is was sent to me. This is a patient who came into an emergency department, was a sober patient. The physician that took care of him said there were no mental health issues. They were there for really just a medical issue. And they took in the discharge paperwork, and the patient signed it and then walked by the desk and said, thanks, I really appreciate it, and walked out. And when they got the discharge paperwork, they'd written a curse word and said, I hate you. So clearly, in real life, we see this disconnect between we think the patients understand, we think the patients are having a good encounter when we go to discharge them. That really may not be the case. Some of the confusion about the discharge process is there's just a ton of variability. So I've worked at places where we have really lengthy computerized handouts that we can send the patients out with. I've worked at places where you've got just really a notepad essentially to write what you want them to do. And then I've worked at places where you could do verbal discharge instructions. So there's a lot. If a patient goes to 3 different hospitals, they may well have 3 different kind of processes in terms of how they leave. And the reason we've got this variability is because we really don't have good evidence to say that one approach is better than any other approach. This is an interesting study. Lawrence et al. Published this in 2009. And it was a pediatric emergency department in a suburban area. And they were switching from one kind of paper charting system to an electronic health record. And so it was a before and after study. And they said, okay, we're going from handwritten instructions to computerized instructions. And they found that when they switched to the computerized instructions, which their hypothesis was that would be a better kind of more descriptive process, that the rates of things that mattered, did the patients bounce back? The return rates at 72 hours were the same. So switching systems in this study didn't seem to improve the discharge process at all. We think of computers when it comes to the discharge process as being helpful, because rather than me having to write out a bunch of directions, I can hit a few buttons. But there are cases, and there are a fair number of cases, where the computerized discharge instructions actually can be problematic. So there was a case in another state where a patient was seen in the emergency department, had some vague abdominal pain. was diagnosed with gastroenteritis. And they were told, the clinician told the scribe, print up some paperwork for gastroenteritis and give it for them to go home. And then they sent the patient out, and the patient ended up having a perforated appendicitis and came back and had a kind of prolonged bad outcome. And the allegation that came up in court was that the clinician had failed to consider the diagnosis of appendicitis. And the evidence they used was, well, you didn't send them out with abdominal pain paperwork. You didn't send them out with potential appendicitis paperwork. You were so convinced you printed up 12 pages about gastroenteritis, and you were wrong. You failed to consider that this could have been something other than gastroenteritis. And they said you kind of anchored on that one diagnosis. Does that seem ridiculous to me? Yes, that seems very ridiculous. Is that something that was used in court in a case that ultimately went the way of the plaintiff, so the physician lost that case? Yeah, so I think we have to be very careful with what we're doing with discharge instructions, even if we've got really expensive, fancy computerized paperwork we can give patients. Really, when you look at the literature and the evidence in the court cases that are out there, what seems to matter the most is not necessarily the format of how we do the discharge process, but it's really there are a couple of elements that I think should be there for us to really be hitting at a best practice. So we need to be time and action specific. We should give patients written and verbal discharge instructions, and we'll talk about that. And then there's this idea of get your own rebound, and that's a little kind of a customer service spin on this. Time specificity is really important. So we need to tell patients if we think they need follow-up, we need to be as clear as we possibly can about when they should follow up. And you need to see somebody in 1 to 2 days. You need to see somebody in a month. You need to come back and see somebody in a year. There's an interesting lawsuit. It's a weird case. There was a patient who had, it sounds like a chronic lumbar wound, and they went to their primary care doctor. And they were told, this wound looks kind of deep, kind of bad. You need to go see a surgeon. And what they put in the discharge process was, and in the chart was when available. And so the patient went out, and I guess the patient didn't think the surgeon was available, and the patient didn't think they were available to call the surgeon. And so they never followed up, and they developed osteomyelitis and had a really bad outcome. And they sued, and the allegation was, well, you didn't tell me. You weren't specific. You just said when available, and it turns out we weren't available. And when this was litigated, the court maintained and the court held that patients are not expected to be their own doctor, that they're not mind readers, but they're also not medical professionals. And so to just say, when available, this court case said that puts too much responsibility on the patient. Again, the other cases have gone different directions, but really we want to be as time specific as possible with patients so that we're not leaving big question marks in terms of when do I want you to go do the next step. The other ways, if we are specific, there are cases we can point to that say that was actually really protective. There was a patient that came in, they initially diagnosed him as gastroenteritis. But they said, listen, your belly hurts a little bit. We didn't do a huge workup here. You seem fine, but I want you to go see your doctor in 1 to 2 days. So the patient goes home, did not go see their doctor, and then 14 days later came back with perforated appendicitis with a big intra-abdominal abscess. One of the recurring themes is that anytime we're sending somebody out, it's probably going to end up being perf appendicitis that gets us. But again, in this case, it pops its head up. And what the courts maintained was, listen, you as the clinician told this patient and their family 1 to 2 days, and they chose to wait 14 days before they saw anybody. And so that shifted the responsibility off of the clinician onto the patient, and the clinician won that case, was dropped from the case. So time specificity, I think, is really important with patients. The other thing is action specificity. And with this, we want to be as specific as possible for the patients. There's an interesting case. This is a patient who's a manual laborer, and they'd come in and they had finger pain, and they got diagnosed with a finger strain. And they put them in a foam splint and said, leave this on for a couple of days. And in terms of follow-up, just follow-up as needed. If you need to see somebody, go see somebody, but otherwise you should be fine. And the patient was not medical, took their splint off, the finger wasn't really working too well, but tried to go back to work, was unable to do their job doing manual labor because they couldn't extend their finger. Subsequently went to a hand surgeon, was diagnosed with a missed tendon disruption and had to have surgery, and so sued the initial clinician saying, you said follow-up is needed, but how am I supposed to know what that means? I didn't know what to expect clinically. And like that first case with the lumbar wound, what the court maintained was, listen, we can't expect patients to fully be their own doctor. So if we're worried about something, rather than saying follow-up is needed, say take the splint off if you have any trouble with range of motion, if you have any continued pain or weakness, then follow up. So time specificity and action specificity are really important. One of the next elements is we need to give written and verbal discharge instructions. And this isn't talking about the whole format, should we write them down versus should we just talk to patients? I think the combination of both really is the best practice. There's a case here, Cleland versus Hayes. And so what happened here was there's a patient who'd come into the emergency department. They had right lower quadrant pain. They'd got an ultrasound that showed an ovarian cyst. They had labs done, showed a white count of 14,000. The patient was afebrile, really felt better in the emergency department after a little bit of fluid. And so the emergency physician discharged him with written paperwork for ovarian cyst. But in the chart, they had a phrase that said, hey, I gave them common sense verbal return instructions. The patient went home and had, you should know by now, perforated appendicitis, came back to the hospital, ended up needing a partial colectomy, and sued. And the case was initially decided against the physician, but on appeal, the appeals court vindicated the physician and said the discharge instructions as a whole didn't fall below the applicable standard of care. So what they said is, look, you gave them the paperwork was not complete because you didn't say anything about the potential for appendicitis or the return instructions for appendicitis, but you do get credit because you coupled that with what you described, and all they wrote in the chart was common sense verbal discharge instructions. So kind of claiming, hey, listen, I talked to them and told them things that if they were worried that they should come back and see us for. So we should have good time and action specific written discharge instructions, but also talk to the patient, common sense discussion. Hey, these are the things you should, if any of this stuff happens, come back and see us. The last part is get your own rebounds. And this is a concept that took a while for me to really fully embrace. One of the 6 dirtiest words in emergency medicine, I think, are, hey, do you remember that patient? I was trained that's horrible. You walk in, hey, Delaney, do you remember that patient? And it's never for somebody to tell you, you took excellent care of the patient. It's always gonna be, they went home, you didn't know what they had the first time, they came back and I figured it out. Or you sent them home, their pain got worse, their symptoms got worse, and they had to come back. And I always thought of that as like, that's a demerit. I don't ever want patients to come back. But really kind of thinking about the process, the absolute best thing that could happen would be if I have a patient and something is wrong, if we misdiagnose them initially or miss what's going on, or if they get worse, if they've got food poisoning and they are thrown up at home and need to come back to the hospital, I want to get my own rebound. The best thing is that they come back, they see me or one of my partners, and this is from a risk management, also a business and customer service standpoint. Come back and see us. Give us another chance to do right by you, because the worst thing would be they go to another hospital and somebody's like, oh, that Delaney guy down the street, he's a moron. He didn't know what he was doing, because then the patient thinks, so that Delaney guy really must be a moron if other people are saying that. And I wish that weren't hyperbole, but we all know the tendency within the house of medicine to talk bad about other clinicians. And so I think this idea, when I see patients, what I do is I try to sit down with them and say, I think you're going to be okay. I wouldn't send you home otherwise, but this is an inexact science at best. And what I tell them and what I chart is, look, if you get worse or develop any new signs or symptoms, come immediately back to the emergency department. So when I say that, what I'm doing is I'm doing my common sense directions. I'm setting up to get my own rebound. You come back, you tell them that you saw Delaney. And if I'm on, I'll see you. If not, one of my partners will see you and take good care of you. So I'm setting them up with the reality that, yeah, there's some percentage chance that we're going to need to see you again, and we want to be the people to care for you. And then I'm going to be action specific and time specific. I want you to come immediately back to the emergency department. And I also try to leave signs and symptoms that should prompt a return kind of vague. This is a little bit of a gray area when it comes to risk management. So some folks are a fan of listing off, if you have a headache, I'm going to list off every potential thing that could suggest you have meningitis. And I'm going to give a patient a really exhaustive list of, if one of these 40 symptoms happened, you need to come back. The other school of thought, and I kind of come down on the side of, again, I'm not expecting my patients to doctor themselves. And if they're worried, if you go home and you're worried, and I'll tell them this, I'd rather see you back 99 times and tell you 99 times out of 100 you're fine than have you sit at home and try to read through my paperwork and figure out, is this a sign or symptom that should kind of prompt you to return to the ER? So time and action specific, and then also set it up to get your own rebound with the patients. And then we all talk to our patients, but document that we had that verbal discussion to go hand in hand with the written instructions we give patients. We will end with, I think, the hottest area, the area that I think makes all of us kind of crazy. The idea that we're being recorded by people we're trying to provide care for. I don't like the idea of being recorded, ironically, as I'm being recorded. I for years, had patients record me, or I occasionally, once or twice a year, a patient will pull out a camera. It's usually a drunk frat boy trying to repair a video laceration repair. But when I talked to clinicians, most of us don't like this idea. We have hospital policies against recording. It's interesting, though, when you look at the general population, the public disagrees with us strongly. So a recent survey found that 15% of people surveyed said, yeah, I have recorded an interaction with a healthcare provider. Pretty high number. 11% of people on top of that 15% said, I haven't done it, but I'm 1 degree connected to somebody who did. So my sister does it all the time, or my wife did it when she went to her OBGYNs. All right, that's still a minority of people. Most people are on our side. Turns out they're not. So on top of those, 35% of people said, I haven't done it. I don't know somebody who's done it, but I don't care. I think I'm at worst neutral. I think it's totally fine to record an encounter, a medical encounter. It's my encounter, it's my body. I can record whatever I want to record. So on the clinician side, I think we all think, oh my gosh, you can't possibly record. But we've got a recent survey that says, well, the public thinks the opposite. And we're starting to see lawsuits. This lawsuit is totally bonkers. So this was in the DC metro area. There's a patient who went in for, it sounds like a screening colonoscopy. Now, there's some suggestion in the news reports that there's a little bit of a backstory possibly between this patient and this clinician. Maybe they had an unpleasant encounter before, but in any event, the patient was willing to let this gastroenterologist perform their colonoscopy. So they go in for the colonoscopy and they get their smartphone and start recording and put it under the bed. And then they just record the whole process on audio. And during the procedure, the gastroenterologist made a couple of disparaging remarks, talked about, or said, we're gonna tell him he's got bad hemorrhoids. They made some derogatory comments about his body habitus. But the procedure technically went fine. The patient, again, was under anesthesia for the whole thing, wasn't awake, but went home, listened to this audio recording, and said that's caused emotional distress to the point that I'm damaged. And so they sued the gastroenterologist for defamation of character and also malpractice and won $500,000. So I'll say we should not talk about patients like that. Absolutely not. The gastroenterologist was wrong for that. But the fact that that has now been deemed malpractice and a $500,000 verdict paid out, I think is totally crazy. The problem is the plaintiff's lawyers don't agree with us, the general public don't agree with us, and so now plaintiff's lawyers are actively looking for cases where they can get recorded evidence of encounters with healthcare providers for this exact kind of case. This is easy money for them. You play that in court, you're gonna settle that. You're not gonna go take that in front of a jury. So recording is tricky. So there are really two types of recording. There's overt recording. And that's when a patient says, hi, listen, and I had this the other night. They said, my son is a physical therapist. Y'all don't let visitors come in because of coronavirus. Can I record what you're telling me so I can play it for my son? And I said, that's absolutely fine. So overt recording, you tell me you're gonna do it, you do it. No harm, no foul. Most of the time it's covert recording. Most of my patients, turns out, I think when I guess the ones who are good at covert recording, I don't find out. The others look like they failed out of spy academy, so they're just kind of hiding the phone in their shirt, or I had somebody actually have it coming out from under their wig, which I really did respect, but covert recording is really what we're worried about, which is we are being recorded and we don't know we're being recorded. And I started talking about this with some partners, and they said, that's illegal. That's gotta be illegal. So let's look. The Electronic Communications Privacy Act, if we're gonna point to something and say, this is illegal, this is the federal act that we can point to. And what this says, and this has been put around on social media, that you can't record a conversation without consent. And I read that, I'm like, that's great. So I can tell patients, you are violating a law, you're violating a federal act by recording without consent. The problem is the devil's in the details here. So this act does broadly state that you can't record people without consent, but in a lot of states, every state in red, I think most of us live in one of these red states, statistically, these are one-party consent states, which means that if you're gonna record a conversation, only one person in that conversation has to consent, and that's the person recording. So I practice in Alabama. If somebody wants to covertly record me, that is in no way illegal. In fact, the law protects their right as long as the person recording consents, which obviously they turned on the recorder, they've consented. In some of these states, California's got a click rule, so they're a two-party consent state, which means that both parties have to consent. But they can do this thing, and this pops up on like TV shows and spy movies, is the phone will click, the line will click. And then in some states, and California has this, that is the acknowledgement that you're being recorded. And so it's not necessarily they say, hey, can I record you? It can be more subtle than that. So most of us are in one-party consent states, and even in a two-party consent state, it's not clear that it's a very obvious consent that we're being offered. We, at our hospital, most hospitals have policies against recording. The problem is that a lot of these policies actually contradict the law, and patients actually understand the law in a lot of these states. When I've talked to patients, there was a case that I was made aware of where a patient was going to CAT scan, the bed rail was down, and they fell out of the bed onto the ground, and they got a big hematoma on their leg. And the family members were upset. And again, that was a medical error. The patient shouldn't have fallen to the ground. And they took pictures, and the clinician walked in and said, "Oh, you're not allowed to take pictures. It's illegal. It's against our hospital policy." And the patient said, "I'm within my rights to take pictures if I want." And the clinician called the police, the hospital police, who came, and they tried to take the patient's phone and delete the pictures, citing this hospital policy. What that does, number one, that's you can't do that. No matter what the hospital policy says, we're still beholden to the law of the state that we live in. But also, that takes a situation where I think the wisest risk management strategy would be to say, yeah, this shouldn't have happened. Let's be sure we get a good documentation of this, and so we can make sure that they get the care they need. But when you start doing things like telling patients that the family they're not allowed to do things, they're not allowed to document this, you can't take pictures of this, that really escalates the stakes. And you bring in security or police and say, give us your phone, or we're going to kick you out unless you delete the pictures. Really, that's a setup for a lawsuit. So. Recording providers, I don't like it. I don't enjoy being recorded. The public disagrees, and the law is on the side of the public. And so what I've tried to do is every single time I go in a room now, with everybody having a smartphone in their pocket, I think the reality is we could be recorded at all times. I think ethically and from a professionalism standpoint, that's helped me kind of say, you know what, I'm not going to get into it. If a patient's really pushing my buttons or it's a very difficult encounter, this isn't the time to get the last word in. This isn't the time to be smart. This isn't the time to use foul language. Really, I think to manage this risk, if we acknowledge patients can do this, patients want to do this, and if we act like if we assume we're being recorded at all times, I think that's probably the safest way to get out of this kind of medical legal quagmire. So again, talking about risk, sometimes it's obvious, sometimes you and I are never going to see it coming in a million years, but I think when we think about things like metadata, every time you do something with the computer, it's being preserved. Folks can find that, so I think we just have to be careful about how we use or fail to use the computer. Fluoroquinolones are still effective agents. I use them on a near daily basis, but I do a 20-second pause, talk to the patient, put something in the chart talking about that discussion we had. Discharge instructions, it's going to be different where you work compared to where I work, but the big things are going to be as specific as possible with patients. Give yourself credit for giving them common sense return instructions. And again, a patient coming back because things jumped off track is a good thing because they're giving us another chance to take care of them. In recording providers, you're on camera, whether you like it or not. The law is not on your side with this one. I wish that weren't the case. But again, we can't avoid all risk, but I think if we look at some of these areas, we can really decrease some of these things that we do on a near daily basis. If you have questions, concerns, have a case you want to share, this is my email. I'm on Twitter, and be happy to answer any questions you have.